Ladies and gentlemen, my talk today is about congenital anomalies of the larynx, trauma of the larynx, and inflammations of the larynx. As regards congenital laryngeal anomalies, we have a lot of classifications that's worldwide accepted. For simplifying the classification, we have divided this into glottic, supraglottic, and subglottic anomalies. For the glottic anomalies, we have considered a laryngeal web and the cord paralysis, and we will discuss laryngeal web in details. For supraglottic anomalies, we have considered laryngomalacia, cysts, and laryngoceles, and we will discuss laryngomalacia in details. For subglottic anomalies, we have hemangioma, subglottic stenosis, and posterior cleft, and we will discuss hemangioma and subglottic stenosis in some details. For the congenital web, at the start it is a fibrous band present between the anterior part of the two vocal folds. We don't have what's called a posterior web. It is always an anterior web, and we have these two photos showing a normal larynx on the left side and a laryngeal web on the right side. And you can see that it is a fibrous band which is present between the two vocal folds with a sharp posterior crescent border, which could be pinkish and grayish or in color. As regard the symptomatology, it would differ according to the extent of the web. If you have the upper photo, which shows a normal larynx, mid photo is a form of a mild to moderate web, and the lower photo which would show a severe degree of web. So this infant usually have what's called a mother complaint of a hoarse cry. In case of extensive web, we would have dyspnea and stridor in severe cases. And of course, this could be detected and evaluated using indirect laryngoscope or direct laryngoscope, and as a screening for early detection and examination, we can use fiber optic laryngoscopy. As regard management and treatment, once it is diagnosed, this is a surgical condition which need microlaryngeal surgery. If the condition is so severe and the need emergency tracheostomy, that could be done immediately, and later we can do surgical intervention. But if the case of mild to moderate web which is compromised the airway, the child can wait to have later surgery. It's better to wait for a couple of years or more, then we do surgical intervention in the form of microlaryngeal surgery or using laser. This slide would show the technology. You are not required to have this, but you should know that when it is removed, it is made in a special pattern which is so sophisticated for undergraduate, but just showing how it is done. Second, we will have laryngomalacia. Laryngomalacia is that anomaly which is considered the most common cause of congenital stridor in children, and there are a lot of theories showing that laryngomalacia is occurring in infant, and it is considered one of the causes of what's called sudden infant death syndrome. As regards its etiology or pathogenesis, some say that it could be due to GERD, some say that it is due to malacia of the cartilage, which proved on post-mortem histologic examination that the cartilage have normal histological structure and there is no laryngomalacia. So they began to consider what's called the theory of exaggerated infantile larynx. If we have what's called infantile larynx, so we have what's called adult larynx. For the undergraduate, it is not significant to know anatomically or histologically the difference between the infant larynx and adult larynx, but as you see in the upper photo, as regards the infant larynx, there is what's called omega-shaped epiglottis, which is usually exaggerating than usual in laryngomalacia, a shortened epiglottic fold that even you cannot detect it, a prominent arytenoid than usual, and below is laryngeal mucosa. This would cause what's called laryngeal inlet collapse, Laryngeal inlet collapse that occur usually during inspiration, and this slide show you the sequence during inspiration of laryngeal inlet collapse that end with complete obstruction of the larynx, and this is explained by what's called the Bernoulli effect, which once there is increase in the velocity of the air during inspiration, there is a negative pressure that lead to sucking in of laryngeal inlet, and this is the most accepted theory till now. As regard treatment, we should know that this patient usually have a normal voice because the vocal cords are not affected, and there's usually failure to thrive or severe respiratory distress during inspiration. However, treatment is usually conservative and assurance of the mother by giving suckling or feeding in interrupted manner and laying the child in a prone position or semilateral position, not in supine position. It is usually obstructed in supine position. The condition usually improves by the age of 2 to 5 years. Very rarely tracheostomy is required in severe cases with failure to thrive and cannot have a normal way and stressed frequently with cyclical cyanosis. In this case, we would do tracheostomy. Some other procedures have been recommended, like what is called the epiglottobiopsy or wedge resection of the area epiglottic fold to release the epiglottis from its attachment. And as long as there are several modalities, we should know that none of them is ideal. As regards assistant laryngeal or hemangioma and subglottic stenosis, just for short notes, we should know that the cyst is a cavity filled with fluid and lined by epithelium that usually occur in the supraglottic regions, that would mostly in the epiglottis, and it may cause some form of discomfort or swallowing if it is large enough, and we remove it usually by microlaryngeal surgery in a fashion called marsupialization or deroofing of the cyst to turn it into an open cavity. Laryngeal, it is another form of the cyst, but it is filled with air. Laryngeal is a cavity filled with air which arises from saccule of the ventricle. The saccule is depression which present in the anterior part of the ventricle, and in those patients which would perform Valsalva maneuver in frequent manner, Valsalva maneuver which we cause straining against closed glottis that lead to simple dilatation of the saccule due to congenital weakness. This dilatation with the frequent maneuvers of Valsalva is getting larger and larger laryngeal that follow its way through the least resistance and sometimes appear at the vallecula, what's called the internal laryngeal, or perforate through the thyrohyoid membrane and appear in the neck and called the external laryngeals, and sometimes it is combined in 50% of the cases, and we have what's called mixed or combined laryngeal with an internal and external component, and the treatment is usually surgical external approach. For hemangioma, simply it could be a part of other syndromes like Sturge-Weber syndromes, where the hemangioma usually occur in the subglottic region. However, interestingly, this hemangioma usually disappear by the age of 2 years and usually affect the airway due to its encroachment upon the airway, and improve by the age of 2 years by spontaneous resolution. Some suggested some form of treatment, some suggested some forms of treatment like laser, like cryotherapy, like injection sclerotherapy. However, it is better to leave it until it disappears spontaneously. For the subglottic stenosis, this could be a part of two. Either it is hard subglottic stenosis or membranous subglottic stenosis. The membranous one that could be managed by simple microsurgery and dilatation. For the hard subglottic stenosis, where there is thickening of the cricoid itself, we can do endoscopic evaluation and what's called curing from inside to dilate the cricoid cartilage, or we can do an external approach in case of severe respiratory distress by using what's called cricoidoplasty or cricoidopexy, where we split the arch of the cricoid in the midline and we insert a costal cartilage to keep it widened in place. And however, this is one of the most sophisticated operations. Let's go to trauma of the larynx. Trauma of the larynx, the most important subject of it is the inhaled foreign body. Inhaled foreign body differs from a solid foreign body in the issue that solid foreign body usually it is arrested in the one of the inlet of the esophagus. For inhaled of the foreign body, it is usually aspirated through the airway, through the larynx, trachea, or the bronchi. This usually occurs in children more than adult. The child would inhale the foreign body either during sleep or laughing or when frightened. We have two types of foreign body, vegetable and non-vegetable foreign body. Vegetable like seeds and beans, and non-vegetable like beans, beads, and tooth, especially artificial tooth. The symptoms usually occur in this frequency where there is inhalation of the foreign body, choking, laryngeal spasm, stridor, cyanosis, and maybe most of us would pass through this case scenario during drinking or during eating. And the foreign body is either coughed outside successively or inhaled inside. Once it passes through the larynx, it usually passes through this wide calibrated trachea and arrests at one of the bronchi, usually the right bronchus, because it is shorter, wider, and more in line with the trachea. And we have one of two case scenarios in these cases: either complete obstruction of the bronchus that will lead to what's called atelectasis or lung collapse, or partial obstruction of the bronchus that allow inhaled air or inspiration, but during expiration it get locking of the bronchus, what's called valve-like effect, and the result in accumulation of air inside that lead to emphysema. So for the mid figure, it shows that complete obstruction of the bronchus with lung collapse or atelectasis, and for the right figure it would show the accumulation of air inside with a valve-like effect that allow inspiration and prevent expiration, and this would increase the air inside and lead to emphysema. And for clinical diagnosis or differentiation between both, on auscultation we have no air entry on atelectasis or collapse, and we have diminished air entry in case of emphysema. And on percussion of the chest we have dullness over atelectasis and hyperresonance over the emphysema. Also would have mediastinal shift. Mediastinal shift is usually toward the diseased side in case of lung collapse or atelectasis, and we have mediastinal shift toward the normal side in case of emphysema, and the mediastinal shift is usually detected radiologically. Usually this patient passes through these stages: the initial phase where there is choking and coughing, the quiescent phase where the foreign body is settled in the bronchi, and lastly the manifest phase when he came later, especially in organic foreign body, with chest infection, cough, dyspnea, and asthmatic wheezes. And this may lead to inflammation like tracheobronchitis, like lung abscess. For the investigation, X-ray would be helpful, especially in radio-opaque material, or would show the complication. But for management, we would have at first what's called first aid management, dislodging of the laryngeal foreign body in urgent situation where there is obstruction of the laryngeal inlet. We do what's called pack slab of the over the pack of the child or the adult, just to move the foreign body and allow it to cuff it, or we do what's called Heimlich maneuver or abdominal thrust to allow extraction and cuffing of the foreign body. In case we are settled, we will go to the hospital for laryngoscope, bronchoscope to remove the foreign body, and you should keep always in mind that any foreign body in your body should be removed from your body. Tracheostomy whether emergency tracheostomy or agent cricothyrotomy, that in case of emergency, in case of laryngeal obstructions. Other types of external trauma will go in a hurry, through a cut throat, or through a bullet, or through blunt trauma to the neck like in boxing, or like in our photo to the left in the second row where it is in hanging. However, all of these are common in causing a form of trauma, laceration of the vocal fold with laryngeal edema, hematoma, and sometimes cause paralysis due to injury of the recurrent laryngeal nerve. Other types of trauma like inhalation of vapor, or like ingestion of some corrosives, and this is however not common nowadays. That would cause burns of the oral cavity, oral mucosa, oropharynx, and esophageal mucosa with laryngeal edema and sometimes stridor. Of course, they are common in the symptomatology of stridor, dyspnea, and the change of voice in the form of hoarseness. Of course, you would take the laryngeal edema or the surgical emphysema or skin injury or the bleeding or fracture of the cartilage or hematoma laceration, and the treatment in emergency intubation if it's possible, or tracheostomy in case of impossible intubation, followed by control of the bleeding and surgical repair of the trauma. As regards the inflammation of the larynx, we have what's called acute and chronic inflammation, specific or non-specific inflammation, and we will discuss certain issues as regards the inflammation. For acute non-specific laryngitis, maybe most of us would have passed through this laryngitis during common cold or influenza, and the most important is acute epiglottitis, laryngotracheal bronchitis. We'll discuss in detail. For the acute laryngitis, there is usually predisposing factor, general like low resistance, bad hygiene or allergy, local like abuse of voice in teachers and those who usually use your voice loudly, or smoking and alcohol, or source of infection in your body like pharyngitis, sinusitis, or maybe part of upper respiratory tract infection. The symptoms usually hoarseness in adult, but children are more vulnerable that will develop stridor because the larynx is small, the lumen is narrow, and the cartilage are soft. The mucosa is usually lax and easily to develop edema. On examination by indirect laryngoscope or fiber optic laryngoscopy, you can use congestion and edema of the vocal folds in adult and subglottic edema in children. For the treatment, usually we use antibiotic, anti-allergic in allergic patient, and corticosteroids, sometimes mandatory in children in emergency situation. And it is a case where we do admission to the hospital, and we advise vocal rest, tension benzoin inhalation, and oxygen in children. Tracheostomy very rarely indicated. As regards acute epiglottitis, is a form of severe laryngitis, usually occur in infant and children. The most common organism is Haemophilus influenza type B, where there is ballooning and severe inflammation and edema of the epiglottis. This patient usually have fever, dysphagia, salivation, muffled voice, and lastly would develop dyspnea and stridor. And you can detect this edema and ballooning of epiglottis and the epiglottic fold, and the treatment is similar to acute laryngitis. Acute laryngotracheal bronchitis, it is another form of severe form of laryngitis, which usually occur in infant and young children. Organism Streptococcus hemolyticus is usually the most frequent, and the clinical picture is similar to acute laryngitis, but the symptoms are more severe, with high fever, marked dyspnea, stridor, and cyanosis, croupy cough, and expectoration. Treatment also similar to acute laryngitis, but you have to add medication for the chest like mucolytic expectorant are used instead of cough sedatives. As regards the acute specific laryngitis, diphtheretic laryngitis, this issue will be discussed in details in facial diphtheria. And the first reported case in tracheostomy in the history is in a case of diphtheretic laryngitis. However, we're not good in the details of diphtheretic laryngitis because it usually occurs second to facial diphtheria, and this is discussed elsewhere. For the chronic laryngitis, we have non-specific and specific. For non-specific, hypertrophic and atrophic. Hypertrophic, it could be diffuse or localized. Localized, we'll discuss the nodules, polyps, leukoplakia, and for the specific we have scleroma, TB, and syphilis, which are usually discussed in details in the news, but we will mention here what is important issue as regard the larynx. The chronic diffuse hypertrophic laryngitis, usually there is a persistent predisposing factor like voice abuse, sinusitis, tonsillitis, smoking, or reflux. This patient usually has hoarseness of voice, dry irritating cough, hemming, and hawking. Signs, we usually have this symmetrical hypertrophy of laryngeal mucosa, which are swollen and pale, with a swollen and pale vocal folds, and we call this rhinx edema. And you should keep in mind that rhinx edema is not a medical condition, it is a surgical condition, which usually treated by microlaryngeal surgery with stripping of the mucosa. As regards the treatment, we should know that elimination of the predisposing factor is important, not to allow recurrence of the rhinx edema. Vocal rest, speech therapy with our speech phoniatricians, antibiotic, mucolytic steroids, and vocal cord stripping by microlaser surgery or laser. As regards the vocal nodules or finger nodes, unorganized hematoma or epithelial, localized epithelial hyperkeratosis in one or both vocal cords, and usually it is bilaterally detected at the junction of the anterior and the middle thirds in patients who use their voice frequently, like singers and teachers. This patient have hoarseness of voice, and it is usually smooth, raised, which nodule at the junction of the anterior and the middle third on both vocal folds. Treatment, again, voice rest and topical steroid speech therapy in early cases, and the excision by microlaser surgery or laser in advanced cases, followed by speech surgery to avoid recurrence. As regards localized hypertrophic laryngitis, we have an issue of leukoplakia. Leukoplakia is a milky white patch which is present above the mucosa, and it is usually due to hyperkeratosis and the hyperplasia of the epithelium, but there is usually intact basement membrane. This leukoplakia usually caused due to persistent irritation by smoking and alcohol. The patient usually have hoarseness of voice, and you can dig this white raised patch simply on examination. Treatment is very important that we would do vocal cord stripping by microlaser surgery or laser, and send it for pathology to detect any malignancy. And in case it shows carcinoma in situ or invasive carcinoma, we should go ahead again and continue treatment. However, if it is free, we have to have what's called a regular observation of this patient, as it is a precancerous condition. As regards the laryngeal polyp, it is a pedunculated or sessile edematous polyp on the vocal fold, which may turn into a fibrous or vascular polyp. This usually occurs at the junction of the anterior and the middle third, causing hoarseness of voice, and the treatment is simply by microlaser surgery followed by speech therapy. Atrophic laryngitis usually occurs due to atrophy of the nose and the pharynx, and usually doesn't occur solo, and the mucosa is pale, glazed, dry, and covered with crust. Hoarseness and stridor may occur. Treatment is by good hygiene of the nose and of the pharynx, like mucolytic, potassium iodide, menthol inhalation, and the laryngeal spray. Endoscopic removal of crust are rarely indicated. For chronic specific laryngitis, what's called the granuloma of the larynx, simply we would have laryngoscleroma, which is so common in Egypt, and it usually occurs due to secondary to rhinoscleroma, and the etiology is Klebsiella rhinoscleromatis bacillus, which is discussed in details in the part of the nose. It's very important to know that laryngoscleroma usually affects the subglottic region, resulting in finally into what's called subglottic stenosis, which may cause stridor and need tracheostomy. Treatment is usually medical in the form of injection of streptomycins or rifampicin using, and the radiotherapy is just mentioned to be abandoned. It is not used anymore. Surgical tracheostomy if indicated, and microlaser surgery or laser evaporation and repeat dilatation for the stenosis. As regard tuberculosis of the larynx, usually second to pulmonary tuberculosis, and we should keep in mind that patient would have TB toxemia, night fever, night sweat, and weight loss. We may have hoarseness, cough, and the most important, we would have pain referred to the ear and stridor in such cases. We should know that in case of TB of the larynx, it usually affects the posterior part of the larynx in the interarytenoid area due to stagnation of sputum in this area and the implantation of the organism. Investigation, the usual investigation for TB, like sputum for TB bacilli, X-ray for the chest, DL and the biopsy, and the treatment, we refer this to chest department for antituberculous drugs and tracheostomy if indicated. Lastly, you would have syphilis of the larynx, usually occur in tertiary stage of the syphilis, and we should know that in tertiary syphilis we have gamma of the epiglottis affecting the anterior part of the larynx, usually over the epiglottis, with the criteria of the gamma that may lead to ulceration, perichondritis, and later fibrosis causing laryngeal stenosis. Investigation, the usual investigation for syphilis, which is not so common in Egypt, like watermelon reaction and the Hans test, usually get positive. Treatment, antisyphilitic treatment as penicillin, tracheostomy if indicated. Thank you.